as we said before, the bulk of the disability occurs in the individuals who have progressive disease. There are also some who have stepwise worsening, who have bad attacks and are left with blindness, motor dysfunction, and such. And in terms of those who do the worst, the primary drivers of that are motor dysfunction and cerebellar dysfunction, if you had to pick two. Cognitive dysfunction as an isolated phenomenon is uncommon. Not unheard of, but uncommon. But as a concomitant to the others, the motor and cerebellar dysfunction, it's there as well. It's just rarely of great importance in the absence of those two. Would you agree with that?
I would agree with that. I think the driver of disability, it's absolutely considered prognostically worse prognosis when you're seeing motor and cerebellar deficits early on. And it's a bit unusual to have cognitive features early on is quite unusual in MS. It would be less than 5%. Over time, if you allow the MS patient to sustain continued hits from their disease, then you begin to disrupt the circuitry of the brain, the cortex, and obviously cognitive issues become more and more common. It's unusual, it's rare, but occasionally you see MS patients where cognitive issues are really the principal feature and their motor is really not that bad, but that's distinctly unusual, I would agree.
How about in your healthcare system? Where do you see the major burden?
Well, you can talk about it from a few different sides. There can be a burden when, as I spoke of this before, when the patient becomes institutionalized and they have to go in to an institutionalist, or they have to have a home health care and other kinds of home health services, et cetera. So that is one of the burdens. If you're talking about for the average patient who's remittent relapsing, the burden is only going to be when they do need medical utilization, when they have the attack, when they have to be, if they do have to be hospitalized, or if they have to come into the outpatient setting. And then I think we'll talk about this later on too, but it's a very, at this point, expensive disease to treat because the therapies themselves are very expensive therapies. So there's a lot of different burdens there. We have the cost, the economic, we have the medical side of it. You've got the home health care side and the institutionalization side. So there's a lot of burden for these patients.
Yeah, I think we look at it in three phases. There's a cost burden that occurs initially when patients present with symptoms, because you're usually going to see a primary care doctor, get referred to a neurologist fairly promptly, and then have a fairly intense diagnostic evaluation period. So that's kind of phase one. Some of those patients will be diagnosed, some won't. The ones who are diagnosed will then very likely receive disease-modifying treatment. So that's phase two of the cost, and as Leslie said, that's the largest portion of the cost. And then phase three are those with progressive disease, which fortunately in most of our plans is the smaller population who ultimately do have that chronic care burden, whether it's home care, chronic care burdens, some institutionalized care, and of course with progressive disability from an employer standpoint, some of these patients will no longer be able to perform their current job duties.